So this is a case that was given to me from a different hospital. Okay. So our patient, Mrs. AM, she is a 31-year-old, first pregnancy, so prime gravida, being induced for post days. Reviewing of her notes, it was uneventful pregnancy. She's literally 41 and 3 days. That's why she's coming in for the induction. Okay. We generally start to assess the CTG before we walk into the room. Okay. What do we think the baseline is going to be? Why are we putting her on the trace? Define risk. She's coming for induction. We're putting her before the induction. Okay. Are we expecting her to be contracting? No, unless she's tightening. She's not reporting any contractions. Okay. Where do we expect the baseline to be?
She's post-date, so just like it to be lower.
Lower than what?
Maybe like, it should be like 120-ish.
Okay. Is there a better way to find out? I mean, yes, you expect it to be at the lower part of the normal. No antenatal CTGs.
Listening in.
Yes. So antenatal notes, heart rate, that was the last time it was listened to, it was at 32 weeks. And at 32 weeks, it was 145. Okay, the next time it was FHHR, and then she's coming to us. So where do we expect the baseline to be? Potentially, so less than 140, definitely less than 140, yeah? This is 8 weeks, 9 weeks later, but definitely less than 140 at least. Okay, so we said we're expecting the baseline to be less than 140, we're expecting variability to be normal, yes? Yeah. Potential accelerations, no decelerations. So we put her on the trace and this is what we're getting. What do we think? Beautiful. Is it? So baseline is 140, accelerative. Yeah, good variability. Okay. So there's lots of contact at the beginning. So the comment that was made, well, the quality is not great. Okay, let's leave it on for another 30 minutes. That's the next 30 minutes. That has confirmed our impression. Yeah? Okay. Are we all happy with the trace? Happy for me to go and get the ProPass? So I'm going to get the ProPass. No, that's what you always have to confirm if you're happy that you need to induce. So I'm going to get the ProPass, and as I'm walking back, this is what I come to find. Are we all happy? Okay, why are you not happy?
Yeah.
Is the baseline about 170 there? Yeah. So if you go back on the trace, let's now go, we can't look into the future, not yet, okay? So if you go back on the trace, was it 170 with D cells all along? What do you think?
Is that continuing on, like immediately?
That is immediately after. There's no gap.
I have a question.
Yeah.
Does she have good fetal movements?
She's feeling. She said the movements were okay, but she can't feel the baby moving right now.
Oh. I wouldn't be worried if there were good movements, but without good movements, I want more trace.
And is the Toco on?
The Toco is on.
So she's not contracting.
She's not saying that she's contracting, and the Toco's not picking anything up. So you say you're not going to be worried if she's saying that there are movements, but she said that the baby was moving up until now. Baby's not moving right now.
Was it moving when the trace was at 170?
No.
Let's just keep going.
Okay. Do you want
just a bit more trace?
Just a bit more trace. So put the ProPass in or put it back in the fridge?
No, let's put it back in.
Okay, fridge for now. And I've just told the lady that we're gonna keep on going for a little bit longer. I'm not entirely sure about the trace. Let's see what's gonna happen a little bit further. She wants just to go to the toilet. She's happy to carry on with the trace, but she just wants to go to the toilet first. And that's the trace when she comes back. Okay, and for another half an hour. What do you think about the trace? So the 140 is here. That's the mark for 140. That's the 160. So
She's fine.
there's no temperature. She is fine.
So what's it being induced for?
Post days. She's 41 and 3 days.
Mm.
And 4 days now. It's 20 past midnight. So 41. And so if we go back on the trace, okay.
Mm-hmm.
Okay, going forward again.
And how are they moving now? Is the baby moving now?
The baby's not, there's no movement at the moment. They said the baby was moving yesterday. At the moment, she's not reporting any concerns about fetal movements, but there's no active movements at this point.
Mm.
And when you don't know very much what to do, you always ask a friend.
Mm.
So the friend that was asked was the registrar on call.
Is there any chance she might be airable?
She's not airable. She's a primate and Bishop score of actually 0. So that works.
Okay.
She can have ProPass.
Yeah.
You can go on ProPass. What's wrong with you? Okay. What do you think the recommendation is going to be? Temperature is normal. Obs are normal. Give what? Give the ProPass.
Yeah. I mean, you can't section her for this. It's not like concerning enough. It's not quite right, but it's not concerning, if that makes sense. Variability is fine. It's got like accelerations. I mean, I have no explanation why the baseline's at 160, but.
Okay. What's your differential diagnosis? So what raises the heart rate, the baseline heart rate? Hypoxia, maternal pyrexia, dehydration.
Prematurity. Yeah.
Prematurity, well, we're 41 and 4, so prematurity doesn't exist here.
But it's not that, yeah.
Okay. So what makes the baseline go up is either hypoxia, pyrexia, or dehydration. And obviously, what's going to be the pick of choice? It's always going to be dehydration.
Yeah.
It always does the trick. Everybody's dehydrated, even though she was literally in the toilet 10 minutes ago.
Yeah.
When we asked her that we're going to carry on the trace, the first thing she asked us to do was to go to the toilet because she had a full bladder. Yeah. But obviously, dehydrated. Now, IV fluid is correct in any CTG. And as you correctly said, the baseline immediately comes down to 140. Why do you think that is? Because she was obviously dehydrated, yes?
Okay.
I wouldn't have been presenting this CTG if she was dehydrated, would I?
Yeah, but it's going to correct any CTG.
Why?
It's like suffocating.
No.
You're cooling the mother.
You're cooling the mother. The fluids that we give are always at room temperature. So this is happening in March. What's room temperature in March in England? 18. Yeah. So you're giving 18 degrees fluid straight into mom's IV system, straight into her bloodstream. You are literally cooling the baby. And what happens to the heart rate with cold? It slows down. Okay.
It would still have acceleration.
So remember, we talked about accelerations are not necessarily always accelerations. If you really, really scrutinize in them, I don't know what you can see from that distance, they're all actually M shapes. Well, as far as we can tell, she's not reporting any contractions. She's not reporting any. So we're going to carry on with the IV, give her her whole liter, and then we think again. So obviously 10 minutes later, she needs to go to the toilet again because she's very dehydrated. There's no fluid at all in her system. Okay, So before she goes, we sign the trace and we stop the IV fluids. She needs to get up, no? Look at how long it takes before the baseline is actually at 160 again. Can you see that? Okay. She goes to the toilet, but we're not paying attention. She comes back from the toilet. Where's the baseline?
Put them back on.
Put them back on. She's due to finish her liter. Well, we've given her a liter. We're not going to throw it away. This is a waste. We do not waste stuff in the NHS. Okay. The moment the IV fluids go on, the baseline comes back down. Okay. And carry on, carry on, carry on. IV fluids discontinued because we're getting bored. It's coming to 3 o'clock in the morning. We started this at 10 p.m. This is 3 o'clock in the morning. Again, within the next 5-6 minutes, can you see where the baseline's gone? And the CTG discontinues. Okay. Now, the retrospectoscope is 100%, yes? It's always 20/20. Retrospectoscope has eyesight of 20/20. So we don't think this was dehydration, no? I mean, the lady peed 3 times within 2 hours. She's very dehydrated. No. Why do you think this was happening? I'm gonna go to the beginning of the trace once again. What's happening? What's going on there?
So do you think this is a raised baseline with Lisa?
Do you think not?
Yeah.
I mean, throughout the rest of the trace, your baseline has been between 160 to 165, okay? Which basically means that these were recurring decelerations. It looks perfectly fine. It looks absolutely fine. And that's the problem with chronic hypoxia. So chronic hypoxia, you can have that variability just because she is getting some, if you look again on the trace, there are squigglies, yeah? Okay. I'm not perfect. I wasn't there. I was not the person there. So she was saying that there are no contractions and I didn't pick anything up. The CTG was not picking up. Whether the TOCO was right or wrong, I don't know. Okay. But let's now imagine what's going to happen now that we've discontinued the trace. What do you think is happening now? I'm going to jump to the part when we discontinued.
Can I just ask, what do you feel like is the significance of, you know, when they're having that kind of trace where you can't tell if it's doing movements from a high baseline, but the baby's moving loads, so that makes
if the baby's moving loads, I would not be worried. This baby was not moving.
So the fact that it wasn't moving when that was happening is what you should making you think more that it's a decel.
Yes. Okay. What do you think is going to happen now that we've stopped the IV fluids and she's now off the trace? What do you think is going to be the trace there? It's going to go back to being tachycardic. Well, it was already tachycardic even before we stopped. And even before we stopped, can you see what's happening again? Okay. So if this is a gradually evolving hypoxia scenario, there is raised baseline, which means that there's adrenaline running. Okay. What's the next step to happen in decompensate or the progress of hypoxia? We're going to reduce variability because the brain is going to be moving. Okay. And eventually, if the brain dies, if this is getting worse and worse and worse, the heart will go into terminal heart failure. Okay. Now, remember at the very beginning, we said with control of heart rate, the heart had its own intrinsic heart rate of 120 to 100, so 120 to 140 beats per minute. Okay. It's modified by the brain. When you have a high baseline, you have some adrenaline running. If the brain dies, after a while, the adrenaline that was circulating runs out. The adrenal glands are part of the sympathetic system. So it needs a brain to secrete adrenaline. If the brain dies, the heart rate is not going to be under any control anymore. The adrenaline will run out. It will actually settle back to its intrinsic heart rate after a while. And if you put her back on the trace, you will find that you have a baseline of 140 that is not responsive to anything at all. It's completely flat. And there is no variability. Except for when there's a contraction, because with ischemia can directly slow down the heart. So sometimes when you get with contractions get more intense, you can get squigglies and decelerations. Okay? She did not get her progress at all. but she is now contracting what, 1, 2, 3, 4, 5 in 10. So that probably tells me that she was probably contracting at the time. Okay, and as things get worse, there is no responses whatsoever. This trace is completely flat. But obviously we're not paying attention to that. We're not looking anymore because we are just, there's no decelerations, it's a happy trace. And the squigglies are sometimes taken as cycling. Well, if you have a completely normal trace, should this baby not be accelerating? Well, she's contracting, maybe not. But you would need to have proper episodes of cycling, not a minute and then it goes back to flat. Okay, what do you think is going to happen next?
It's going to go down.
So nothing. The baby can't decelerate. You need the brain to decelerate. Okay, the only thing that is left is the baby to have the terminal heart failure. Okay, what do you think the outcome is? Neonatal death. No, it was unresuscitated. It was resuscitated for about 35 minutes and then they stopped. There was no heartbeat at any point. And no spontaneous breathing.
So she never got propus or anything. This was without labor. This was essentially an antenatal stillbirth.
Well, she had a section at 11 o'clock or 11, sorry, that's 11:15. So about 12:20. There you go.
Yeah, but it was a stillbirth. It was a death without labor of any sort.
She was
contract.
2010.
But without medicine, so she just went into labor on her own.
She had no medications.
No medication.
So the problem when we give fluids is the masking of the baseline. The baseline will always come down. Okay, if you are giving fluids, you have to be very focused on why you're giving it. You have to have good evidence of dehydration before you're giving it. Not somebody who's peeing 3 times in 2 hours. Okay, and if you've done nothing at all, you saw that, okay, your diagnosis is that this lady was decelerating at a high baseline. You cannot take her off the trace. Even if I'm not going to induce, if I'm going to do absolutely nothing here, I'm just going to wait, I can't take her off the trace, because taking her off the trace means that now, I haven't treated anything. I've given her, splashed some water at her, cooled her off for a couple of hours, and then what? The baby is just going to go back to its hypoxia and it's going to gradually get worse. And obviously the contractions were getting stronger because she was in early labor, which is why the baseline was high to start with. Okay. The problem with chronic hypoxia is that it has a big range.
It's the normal variability that's...
Normal variability gets lost once your brain is going into ischemia. Yes. So you are going to have.
If you section that baby,
I think that baby would have been fine. Nobody can ever swear.
Yeah.
But you can see that you just all went fine. It was actually accelerating at a point. It was responding normally at that point. So I think that the brain at least had enough capacity to respond normally. Okay, but by the morning, literally the break is actually for 3 hours. That's the entire break, 3 hours. And you ended up with a brain dead baby. And 5 hours later with a dead baby.
So when was the right time to section here? If we go back to the beginning.
If I go back to the beginning, so this is where we started.
So here it's difficult to tell what's going on. You can't section that trace.
No, definitely. I wouldn't have sectioned that trace.
So, you know, you're having words with people. This looks like an accelerative trace.
I'm not saying anything, I'm not saying otherwise. So to me, this looks like an accelerative trace. It looks like a perfect trace. Okay.
It looks like that looks fine.
But here I'm withholding the propus, and I said I'm going to observe for a little bit longer. And for the rest of the trace, you can see that there's no, this baseline is actually high. So I have my diagnosis by this point.
Yeah. Yeah, when you have an antenatal trace with a high baseline that you have no explanation for it, as in there's no movement, there's no fever, it's not preterm, then the only is the chronic hypoxia, isn't it?
If
so you just that trace.
So it's just time.
But it, yeah, 5 more minutes. So you have a high baseline, you need to explain it. Okay, and this high baseline, this is, at this point, this is 20 past midnight. The trace started at 10 past 10. So for the last 2 hours, you have persistent tachycardia. Okay, rather than giving her the IV fluids here, so you were asking a friend, I think was an adequate response. Oh, I have a high baseline, I can't explain that. Okay, I've moved her onto her side, so they've changed position, and the baseline has not gone down. Why would I give the IV fluids? This lady's been to the toilet. She does not, she would, I was not there, but I would not have assumed that she looked dehydrated. The fact that she peed 3 times within the 2 hours tells me that she was not dehydrated. Whatever I was giving her, she was peeing. Okay? IV fluids is not the treatment. She did not have any temperature. This might have been chorioamnitis inside, but I don't think so, given that I had decelerations on the trace before. So I have to assume that this is hypoxia until proven otherwise. And unfortunately, she's hypoxic with a Bishop score of 0. So the reality is her treatment is delivery. I believe that had she been sectioned around midnight, we would have had a healthy baby. Are you still there, guys?
Yep.
Does anyone have any questions before we end this?
No, that was a nice case. That was a really scary case.
It just makes you you need to make sure that you're thinking properly. Yeah.
Yeah. Yeah, it's quite hard, you know, when someone comes in for induction and then, you know, you get something like this, and you know, it's a tough one. Do you have any other case? Is that it?
That was it for today.
Thank you very much.